Hello, and thank you for joining this OncLive peer exchange discussion, Practical Implications for New Data in Lung Cancer Systemic Therapy. Research in the field of thoracic oncology continues to provide us with paradigm-changing data in terms of how we treat our patients with systemic therapy. Recently, I was joined by my colleagues, Dr. Hossein Borgai and Dr. Charu Agarwal, in a Twitter chat, during which we discussed some of the practical questions that plague the community oncologist when treating patients with locally advanced and metastatic non-small cell lung cancer. In today's OncLive peer exchange discussion, we're going to explore these questions further as we share the insightful comments that we gathered from both lung cancer specialists and community-based oncologists on Twitter. I'm Dr. Jack West, Medical Director, Thoracic Oncology Program at the Swedish Cancer Institute in Seattle, Washington. Joining me today are Dr. Hossein Borgai, Chief of the Division of Thoracic Medical Oncology and Professor in the Department of Hematology and Oncology at Fox Chase Cancer Center in Philadelphia, Pennsylvania, and Dr. Charu Agarwal, Assistant Professor of Medicine at the Hospital of the University of Pennsylvania, also in Philadelphia. We have a lot of exciting things to cover today. Let's get started on our first topic, the treatment of locally advanced non-small cell lung cancer, and some of the questions that we addressed on Twitter. The Pacific trial looked at the benefit with consolidation durvalumab given for a year in patients who had received and not progressed on concurrent chemo and radiation for unresectable stage 3 non-small cell lung cancer. That is really a standard of care, but unfortunately, a lot of patients are not getting concurrent chemo and radiation, though I think in our practice we generally do. But certainly in some parts of the world, in the UK in particular, there's a lot of patients who get sequential therapy, and even in the United States and some other parts of the world, a lot of patients are not getting concurrent chemoradiation as much as we think they should. Haas, do you have any ideas about why that might be the case?
Thanks, Jack. I really can't tell you that I have data to tell you why that might be the case, except that sometimes in discussions with some of our colleagues, a couple of points come out. One is access to a group that's closely associated with radiation oncologists, where you can coordinate the kind of coordination that it takes to do concurrent chemoradiation. And I think to some extent, I still hear this fear of toxicity or concern for toxicity for a patient population who, for the most part, might not be doing quite as well, because in your locally advanced disease is a difficult disease for a patient to tolerate. So I think there's a little bit of a concern about the toxicity of concurrent approach. Sometimes it is felt that perhaps older, frailer patients should be treated with the sequential approach because that somehow makes it more tolerable. So I think there's a lot of concerns like that that goes into deciding whether someone should get concurrent chemo-RT versus the sequential. There might also be this idea that concurrent chemo-RT, although based on phase 3 results, is clearly superior, the superiority wasn't like 15–20% overall survival, it was much less. So if it's going to be too toxic, why not try the sequential approach? So I think there's a combination of different factors that goes into this decision of whether you should offer concurrent chemo-RT versus sequential.
Yeah, and I think sequential chemoradiation should really be the exception rather than the rule. We certainly see patients that are offered sequential chemoradiation therapy, but usually it's after careful thinking and the thought process of the risk-benefit ratio of the benefit, as you pointed out, versus the risks. If there's somebody who's clearly PS2 and not doing well, and you're concerned about toxicity, older in a wheelchair, I think, a multidisciplinary discussion is still warranted, but I agree, those may be the reasons why sequential therapy is used.
I suspect that some of it may be the practical aspects of coordinating, but I do think a lot of it is just concern about managing the potential for greater acute toxicities. But I think, unfortunately, it's to the detriment of these patient outcomes. And you raised the question of people maybe being skeptical and saying, is it enough of a difference? But I think to most of us, the answer is yes. It's in a curative setting, you want to play for every percentage of cure you can get.